Good day, everyone. I hope everyone's doing well today. I am Dr. Eugene Odono, and I'm here to discuss some applications of molecular testing in bone and soft tissue sarcomas. Bone and soft tissue, or BST sarcomas, are a heterogeneous group of mesenchymal lesions. The classification of these tumors used to be based on their line of differentiation. Now, during the past 2 decades, there is a marked expansion of knowledge regarding the molecular characteristics of these tumors, and so classification of bone and soft tissue sarcomas continues to evolve as a result of incorporating the advances in cytogenetic and molecular techniques. So the characterization of these aberrations opened new avenues for molecular diagnosis. So there are already a lot of molecular tests that have been developed for the diagnosis not just of bone and soft tissue sarcomas but other tumors in general. Unfortunately, not all of these tests are available in our country. So for this talk, I am going to focus on the locally available molecular diagnostic tests for bone and soft tissue sarcomas. So my goal is at the end of this talk, you would be able to, number one, know some of the available molecular diagnostic tests for bone and soft tissue sarcomas that are available in the Philippines, which we will be limited to discussing fluorescence in situ hybridization, which is newly available in some of the centers in our country, such as where I work in, the Philippine General Hospital. Second, to identify the cases and situations in which FISH testing are warranted or will be beneficial. So in short, when to order these tests and when are they needed. Third, to integrate the available molecular diagnostic tests in your diagnostic repertoire. And fourth, to interpret FISH testing results and their impact on patient diagnosis and management. So this is the brief outline of this lecture. First, we're gonna have a brief introduction on the importance of molecular testing for bone and soft tissue sarcomas and some general comments on the usage of molecular testing. Then, we're going to tackle the three FISH tests that are currently available in our center: MDM2 amplification, EWSR1 translocation, and SS18 translocation. And with the discussion of these molecular tests, we're going to have an overview of these tests and show the scenarios in which these tests could be utilized. So let me start first by stating the obvious. Molecular tests are not cheap. And especially in a setting such as the Philippines, we must be judicious in ordering these tests. So, when do we need to order these tests and how can we apply them in our diagnostic processes? Now, for sarcomas usually have characteristic histologic patterns. So, your tumor could be a spindle cell, epithelioid, myxoid, round cell, pleomorphic, biphasic tumor. And then, based on the histomorphologic pattern of the tumor, we pathologists request immunohistochemistry tests or IHCs in order to help determine what the tumor is, what's the line of the differentiation, and so on. Now, if the tumor can be diagnosed based on these histomorphologic features, H&E and IHCs, molecular tests are actually not needed. In fact, for many sarcomas characterized by cytogenetic aberrations, such as synovial sarcoma, Ewing sarcoma, or alveolar soft part sarcoma, the latest edition of the WHO classification of bone and soft tissue tumors, or the Blue Book, they only say that demonstration of the cytogenetic aberration via molecular testing is desirable or nice to have and is only necessary in certain cases. So, when or what are these certain cases in which it is necessary to perform these molecular tests? The obvious answer to that question is when, of course, the histomorphology and the IHCs are not conclusive. So these are more specific examples when you might want to consider doing a molecular diagnostic test. So for example, a small biopsy. So when you already have a high pretest probability that you are dealing with a sarcoma with a distinct molecular or cytogenetic aberration and you only have scanty remaining material, you want to avoid making diagnostic errors and you want to avoid a repeat biopsy, you might want to just um, give that scanty material to the molecular testing. Second, poor histologic preservation. So, because poor histologic preservation can complicate interpretation, and this situation can be similar to a small biopsy. You only have limited good material to work with. However, we must be wary that many causes of poor histologic preservation may also make the tissue unsuitable for molecular testing. Third, molecular tests may also be considered when the tumor has unusual morphologic features. For example, a small cell variant of synovial sarcoma. So, molecular testing there can provide reassurance or confirmation of the diagnosis. Molecular tests may also be needed when there are discordant immunohistochemical results. For example, a small blue round cell tumor with only a patchy or weak CD99 staining. Okay. Another example is, for example, when you encounter unusual IHC expression patterns such as a spindle cell tumor with CD34 and S100 co-expression. Another example in which you might want to consider a molecular test would be uncharacteristic clinical features. That may prompt you to consider a molecular diagnostic test in order to confirm a diagnosis. So, for example, it is prudent to do a molecular diagnostic test in a desmoplastic small blue round cell tumor in a woman in her 40s, or the DSRCT occurs in an unusual site. Excessive treatment effect is another situation in which you might want to consider molecular diagnostics, because in these cases, the original histology had been modified by treatment-related changes, making diagnosis difficult. So, molecular testing may help you with these cases. Sometimes clinical trials may also require molecular testing for a definitive diagnosis, okay, to give definitive treatment. Individuals interested in targeted therapy, so that's another use for molecular diagnostics for treatment purposes. And molecular tests may also provide prognostic information. So, for example, these researchers in France recommended molecular testing to be done in pediatric sarcomas such as Ewing sarcoma or primitive neuroectodermal tumor, alveolar rhabdomyosarcoma, and synovial sarcoma because of the prognostic and therapeutic implications in this age group. Molecular diagnostics may also be considered if the prospective diagnosis or the main differential diagnosis is rarely encountered by the diagnosing pathologists, and so a molecular confirmation would be useful. Indeed, there are multiple studies that have examined the importance of molecular diagnostics. In this French multi-center study in 2016, they examined the effect of molecular methods in sarcoma diagnosis and found that molecular testing modified the diagnosis in around 14% of sarcoma cases. Now, focusing on FISH and the three genes that we're discussing today, Nujaim in the UK in 2017 did a retrospective review of their FISH and RT-PCR tests for EWSR1 translocation in their institution. They found out that a positive FISH result led to diagnostic changes in 19% of those EWSR1 rearranged cases. Similarly, Vargas et al. In Australia retrospectively reviewed all routine diagnostic FISH tests over a 5-year period and found that MDM2 FISH results led to a change in diagnosis in 6% of cases, and SS18 FISH results led to a change in diagnosis in 7% of cases. So these numbers are not insignificant. So today, our goal is to learn which of these cases might benefit from FISH testing. Before we go deeper to FISH, so we say, here are just some general reminders on the usage of molecular tests. So molecular testing must be used in the proper context. So selection of a molecular test must be based on specific differential diagnoses and relevant pretest probabilities. So this is pretty much like how you would select your immunohistochemistry panel. So you have your main differential diagnosis, and then you select your IHC panels to rule in or rule out your differentials. So it's the same with molecular tests. Second, now if you get the result of your molecular test, that result must be evaluated in the context of patient history, clinical findings, histomorphology, and immunohistochemistry findings. So you must correlate it with the material that you have already. And third, when the diagnosis is histologically certain, a negative result of a molecular test does not rule out the diagnosis. Remember that all tests have their own sensitivity and specificity. So there will be cases in which the molecular tests will be inconclusive, and you have to fall back on your histomorphology and or immunohistochemistry in order to make the best diagnosis possible. Let's go now to FISH. Fluorescence in situ hybridization, or FISH, is one of the most widespread molecular tests because of its reliability and sensitivity. Failure rates in FISH is lower than in RT-PCR because FISH uses DNA, which is more stable, as opposed to RT-PCR, which uses mRNA, and mRNA is less stable. Now, FISH is also flexible. It is usually done on formalin-fixed, paraffin-embedded tissues, or FFPE tissues, which is easy to get. Sometimes frozen tissue and smears could also be used depending on the capability of the center. Another advantage is that for translocation sarcomas, it only requires the knowledge of the most frequently rearranged translocation partner. So for example, in synovial sarcoma, you can have SS18 fused to SSX1, SSX2, or early SSX4. In many PCR platforms, you need to have primers for SS18 and its possible fusion partners in order to detect the translocation. For FISH, you only need to test whether SS18 is translocated because the test is agnostic to the partner. Now, this same advantage can also be a drawback. So for promiscuous genes such as EWSR1, more on this later, it will not give you the specific translocation. It will only give you information that EWSR1 is translocated. FISH also has its limitations. FISH is not ideal for tumors with a large number of non-neoplastic cells. Second, there may be test failure in tissues decalcified with strong acid, which is why EDTA decalcification is preferred if there is a possibility of molecular testing. Poorly fixed tissues can also cause degradation of the DNA and may cause failure of the test. Also, FISH may not be able to detect small translocations or intrachromosomal translocations where the involved genes are close to each other. Another issue that FISH may have would be with overfixed tissues, which we'll see later. So just a brief overview as to how FISH is done. So for example, we have FFPE, in which we have a section on a slide. Now, the first step is DNA unmasking, in which we put proteases and other enzymes to digest the tissue in order to make the DNA in the target more accessible. So this is where problems in overfixed tissues arise because formaldehyde or formalin would cross-link the DNA, and overfixation would increase these cross-links, making it more difficult to unmask the DNA and necessitating increased digestion. And then with FISH, you put in the probes that target the distinct DNA sequences or areas in the genome of the cells. So the target depends on the design of the probe. So, and then they would be denatured, both the target DNA and the probe DNA. And then the probe DNA is hybridized with the target DNA on the slide. And then if there is hybridization, there would be fluorochromes that would target the labels. So these labels could be color-coded with one color specific for one target. So usually there are two colors that are being used. And then the slides are going to be viewed and read under the fluorescence microscope. So this is essentially a brief overview of how FISH is done. So let's now go to the different FISH tests that are available in our country. First, we have MDM2 amplification. MDM2 is a proto-oncogene located in the long arm of chromosome 12. It encodes a nucleus-localized ubiquitin ligase, which attaches ubiquitin to tumor suppressor proteins like p53 and DAX. So, MDM2 directs these proteins to the proteasome for degradation. So, the effect of MDM2 is inhibition of p53-mediated cell cycle arrest and inhibition of DAX-mediated apoptosis. So from here, it's easy to see why MDM2 amplification can promote tumorigenesis. For sarcomas, it has been found that MDM2 amplification is associated with a typical lipomatous tumor or well-diff liposarcoma, the differentiated liposarcoma, parosteal osteosarcoma, low-grade central osteosarcoma, and intimal sarcoma. So in this group of tumors, it is usually the adipocytic tumors that see the most need for MDM2 amplification testing. IHC for MDM2 is actually available. However, several studies have found issues with MDM2 IHCs. So, typically, when new IHCs are being tested, they're being tested on histologically unambiguous cases or on clear-cut cases, which can show that they work well. So, Servent in 2007 tested the concordance of IHC, FISH, and quantitative PCR, qPCR, for MDM2 amplification in 200 adipocytic tumors. So, in their series, FISH and qPCR results were largely concordant, but IHC had poor concordance with the FISH and qPCR results. So, they recommended to use FISH or qPCR if the IHC is not helpful. Now, Clay in 2016, a more recent study, performed MDM2 and CDK4 immunostaining in 183 well-differentiated adipocytic tumors that are histologically ambiguous, meaning cases that are not clear-cut, and these are the cases that in practice would need or necessitate MDM2 testing. So they found out that there was poor sensitivity of MDM2 IHCs for atypical lipomatous tumor, well-differentiated liposarcoma, with FISH as the golden standard, and only half of the cases of atypical lipomatous tumor, well-diff liposarcoma stained for MDM2 or CDK4. So in short, in clinical practice, MDM2 IHC may not be sufficient to diagnose a typical lipomatous tumor or well-differentiated liposarcoma. There are also some potential pitfalls with MDM2 IHC. Now, since IHC correlates with the expression of the protein and not exactly amplification of the gene, mechanisms that will increase the expression of the protein from non-amplified MDM2 genes will also give you a positive MDM2 IHC result. So, in this 2021 study involving 10 hibernomas, all of them were actually positive for MDM2 IHC but were found to have no MDM2 amplification by FISH. It was found out that these tumors express a protein called USP7, which stabilizes MDM2, resulting in nuclear expression of MDM2 by IHC. So this is important because hibernomas may be a differential diagnosis for a typical lipomatous tumor, well-differentiated liposarcoma. So another MDM2 amplified tumor is the differentiated liposarcoma, and a differential diagnosis for this is malignant peripheral nerve sheath tumor, MPNST. In this 2018 study, 21 out of 68 MPNSTs, or about 30%, were positive for MDM2 IHCs, and all but one are non-amplified, okay, by FISH. So in addition, in my experience, MDM2 IHC is a dirty stain. So it can be difficult to optimize and has a lot of background staining, which can make it difficult to interpret. As such, in some centers, they do not have this MDM2 IHC anymore. They just go straight to FISH. Now, MDM2 FISH detects amplification of the band 1 sub-band 5 region of the long arm of chromosome 12 where the MDM2 gene is. So the test setup is like this. One probe binds to the centromere of chromosome 12, which in this case will be colored green, and the other probe would attach to the area of interest, which in this case will be orange. In a normal cell in which there is no MDM2 amplification, there would be two copies of chromosome 12. So there would be two green signals like the picture on the upper right. So there would also be two copies of MDM2. So there would be also two orange signals. Now, in an abnormal cell in which you would have MDM2 amplification, so there would be a lot more of those orange MDM2 signals compared to the green signals like you see in the picture on the lower right. So the criteria varies from laboratory to laboratory, but in general, MDM2 is considered amplified in a cell if the ratio of orange to green signals, that is, the ratio of MDM2 to chromosome 12 centromeres, is more than 2. So let's now go to the tumors that might benefit from MDM2 testing. A typical lipomatous tumor or well-differentiated liposarcoma are synonymous terms for the same tumor. Well-differentiated liposarcoma is used for tumors within body cavities and paratesticular region because of the significant morbidity in these cases and the increased risk for dedifferentiation. Now, the term atypical lipomatous tumor is appropriate for other areas. Now, a typical lipomatous tumor well-differentiated liposarcoma is a locally aggressive mesenchymal neoplasm composed of atypical adipocytes and at least focal nuclear atypia in the adipocytes and or stromal cells. Now, MDM2 or CDK4 amplification is almost always present. So this is a classic picture of a typical lipomatous tumor well-differentiated liposarcoma. So you have atypical adipocytes at the bottom half of the picture, and the atypical adipocytes are characterized by differences in the sizes of the adipocytes and the lipoblasts. Take note that for ALT well-differentiated liposarcoma, lipoblasts are not necessary for the diagnosis. So at the top half, you see that there are atypical stromal cells which are enlarged and have hyperchromatic nuclei. However, a typical lipomatous tumor well-differentiated liposarcoma has variants such as this one, which can show prominent myxoid stroma that may even resemble myxoid liposarcoma. The clue here are the hyperchromatic atypical stromal cells as indicated by the arrows. So cases like this with a non-classic histology will most likely need molecular testing. Also needing molecular testing would be mimics of a typical lipomatous tumor well-differentiated liposarcoma. So here's a test. Of these 6 cases, how many of these is or are a typical lipomatous tumor well-differentiated liposarcoma? And which of these is a typical lipomatous tumor or well-differentiated liposarcoma? So there's actually just one case that is a typical lipomatous tumor well-differentiated liposarcoma, and that is the case at the center of the bottom row. And of these cases, only one, the atypical lipomatous tumor well-differentiated liposarcoma, will have MDM2 amplification. So let's touch a bit on the differential diagnosis and salient features of some of the differentials for a typical lipomatous tumor well-differentiated liposarcoma. Now, first would be spindle cell lipoma and pleomorphic lipoma. So these tumors are usually subcutaneous, seen at the shoulder, nape, and back of older men. So if it occurs outside this location and age group, think about other differential diagnosis. So spindle cell lipoma, pleomorphic lipoma is composed of mature adipose tissue plus that ropey collagen plus some spindle cells, and you may also have multinucleated tumor giant cells. Now, especially with pleomorphic lipoma, you can have enlarged hyperchromatic cells that could raise suspicion for a typical lipomatous tumor well-differentiated liposarcoma. So it is the ropey collagen and the characteristic location in the shoulder, nape, or back of older men that may assist you in favoring spindle cell lipoma or pleomorphic lipoma. Again, important, spindle cell lipoma, pleomorphic lipoma does not have MDM2 amplification. Now, a typical spindle cell or pleomorphic lipomatous tumor, this entity was formerly known as spindle cell liposarcoma. So these are composed of a well-developed spindle cell component with bland spindle cells in a fibrous to myxoid stroma, and if it is a pleomorphic lipomatous tumor, you may also have pleomorphic cells, which may raise suspicion of a typical lipomatous tumor well-differentiated liposarcoma, and then the adipocytic differentiation is variable. And again, for this entity, there is no MDM2 amplification. Lipoblastoma occurs in a younger population, usually in children less than 3 years of age, although there are rare cases in which it can occur in adults. So the appearance of immature adipose tissue can mimic that of the atypical adipocytes in atypical lipomatous tumor well-differentiated liposarcoma, in which you have a variety in the sizes of the adipocytes with fibrosepta. Now, fat necrosis can also cause changes in adipocyte morphology, in which you may also have variably sized adipocytes, and then the histiocytes may be misconstrued as the enlarged hyperchromatic nuclei as in the picture. But again, for both lipoblastoma and fat necrosis, there is no MDM2 amplification. So for well-differentiated adipocytic tumors, when is MDM2 testing recommended? In general, you do it when the diagnosis of a typical lipomatous tumor well-differentiated liposarcoma is uncertain, or if it is in the differential diagnosis. Now, there is this interesting study in which they tested 301 borderline cases, so meaning cases that are not clear-cut, and they separated them into categories to see which will benefit most from MDM2 fish. Clay et al. Recommended that MDM2 fish testing be done for these categories. First, recurrent lesions or recurrent lipomas. Second, deep extremity lesions that are more than 10 centimeters in size in patients over 50 years of age. Third, in cases in which there is equivocal atypia. Fourth, in lesions of the retroperitoneum, pelvis, and abdomen. And five, in special clinical situations as directed by treating clinicians. So this is the recommendation because it is in these categories wherein a sizable percentage of the borderline tumors turn out to have MDM2 amplification and are thus atypical lipomatous tumor well-differentiated liposarcomas. In contrast, in other categories, such as superficial or subcutaneous lesions that do not meet this criteria, MDM2 fish turned out to be negative in almost all cases, and so MDM2 fish testing is not cost-effective in the other categories not listed here. Now, what about high-grade tumors? So, the differentiated liposarcoma is an atypical lipomatous tumor, well-differentiated liposarcoma that has progressed to a sarcoma, usually non-lipogenic, of variable histologic grade. So, this could be any sarcomatous dedifferentiation. So, it could be rhabdomyosarcomatous, osteosarcomatous, or something resembling undifferentiated pleomorphic sarcoma, and so on. It could be myxoid, epithelioid, spindle cells, it may be inflammatory. There are actually a lot of possibilities. Now, since it is a dedifferentiation of an atypical lipomatous tumor, well-differentiated liposarcoma, it will also have the MDM2 and or CDK4 amplification. Now, if you see the classic version in which you see an identifiable atypical lipomatous tumor, well-differentiated liposarcoma area, plus the sarcomatous component, the diagnosis is easy. So one example is this case. So here you can see the readily identifiable atypical lipomatous tumor, well-differentiated liposarcoma component at the bottom third, while the upper two-thirds is composed of the sarcomatous area that resembles undifferentiated pleomorphic sarcoma. Now, what if the diagnosis is not as clear-cut? Especially when the atypical lipomatous tumor, well-differentiated liposarcoma part is not readily identifiable. Again, here's a test. So, of these 6 cases, how many and which of these is the differentiated liposarcoma? The top 3 pictures actually represent the dedifferentiated component of dedifferentiated liposarcoma. The bottom 3 are some of the possible differential diagnoses of dedifferentiated liposarcoma. You have pleomorphic liposarcoma, malignant peripheral nerve sheath tumor, and undifferentiated pleomorphic sarcoma. And of course, dedifferentiated liposarcoma is MDM2 amplified. So these are the differential diagnoses for dedifferentiated liposarcoma. Now, pleomorphic liposarcoma also occurs in older individuals. So this is a high-grade sarcoma with pleomorphic lipoblasts, as we can see on the slide. The presence of pleomorphic lipoblasts is required to diagnose pleomorphic liposarcoma, and this is one of the few adipocytic tumors that require the presence of lipoblasts in order to make the diagnosis. In pleomorphic liposarcoma, there should be no atypical lipomatous tumor or well-differentiated liposarcoma differentiation present. This is because dedifferentiated liposarcoma can have a so-called homologous dedifferentiation in which the dedifferentiated component is a pleomorphic liposarcoma. Now, undifferentiated pleomorphic sarcoma also occurs in older individuals in the deep soft tissues. It is composed of pleomorphic spindle to polygonal cells with no identifiable line of differentiation based on histomorphology, immunohistochemistry, and that there is no distinct molecular aberration. So, by definition, this is a diagnosis of exclusion, and in order to diagnose undifferentiated pleomorphic sarcoma, one must have done all tests available, and one of those diagnoses that you can exclude is the differentiated liposarcoma. So why is there a need to do MDM2 testing for high-grade pleomorphic tumors? Why do we need to differentiate undifferentiated pleomorphic sarcoma from dedifferentiated liposarcoma? So aside from the fact that undifferentiated pleomorphic sarcoma is a diagnosis of exclusion, dedifferentiated liposarcoma has a relatively more favorable prognosis than most pleomorphic sarcomas as we see on the slide. So for pleomorphic tumors, when is MDM2 testing recommended? So MDM2 FISH analysis is recommended for number 1, for the diagnosis of the differentiated liposarcoma with no well-differentiated component, that is, for high-grade sarcomas with no specific differentiation, wherein rendering a diagnosis of the differentiated liposarcoma will have clinical value over just saying that it's a high-grade pleomorphic spindle cell neoplasm. Second, MDM2 FISH is recommended for retroperitoneal tumors because there is a high chance that this can turn out to be the differentiated liposarcomas. Now, for biopsy cases in which you have a pleomorphic tumor on your slide and the imaging describes an adipocytic component that you don't see on your slide, you might want to consider using or doing MDM2 FISH. And lastly, if your center still does MDM2 IHC and it turns out to be positive, this must be confirmed with MDM2 FISH or PCR because as we have seen, we do have tumors that are MDM2 IHC positive but they have no amplification. Now, there are also two bone tumors that have MDM2 amplification and they actually look quite similar. So, low-grade central osteosarcoma and paraosteal osteosarcoma both usually affect young adults. They are low-grade osteosarcomas composed of moderately cellular fascicles of spindle cells with mild nuclear atypia with thick and long parallel trabeculae of woven bone. Both of them are associated with MDM2 amplifications, and the main difference between low-grade central osteosarcoma and paraosteal osteosarcoma is their location. Low-grade central osteosarcoma is located in the intramedullary area, that's why it's called central osteosarcoma, while paraosteal osteosarcoma is located at the surface of the bone. The two entities mentioned earlier both contain low-grade spindle cell areas with trabeculae of woven bone. So these types of morphology can bring up differentials such as fibrous dysplasia, which is MDM2 non-amplified. So in these cases, you might want to do MDM2 FISH as well. From MDM2, let's now go to EWSR1 translocations. EWSR1 is a gene located at the long arm of chromosome 22, which encodes a multifunctional protein involved in gene expression, cell signaling, and RNA processing. The N-terminal of the protein is a transcriptional activation domain, and the C-terminal is the RNA binding domain. Now, translocations usually involve the EWSR1 N-terminal fusing with the C-terminal DNA binding domain of a transcription factor protein such as FLY1, ERG, or WT1, and this fusion protein now acts as an aberrant transcription factor. EWSR1 has been termed a promiscuous gene. So it's because EWSR1 translocations have been implicated in an increasing array of neoplasms, and these gene rearrangements are oncogenic drivers of a variety of mesenchymal and even epithelial malignancies. This slide is by no means exhaustive, but you can see here the promiscuity of our friend EWSR1. EWSR1 can have multiple gene partners for translocations. So for example, if EWSR1 is fused with the ETS family of genes like FLY1 or ERG, or even non-ETS ones like PATS1 or SMARCA5, it can give rise to Ewing sarcoma. Fusion with WT1 is characteristic of desmoplastic small round cell tumor or DSRCT. Now, extraskeletal myxoid chondrosarcoma is associated with NR4A3 fusions, of which EWSR1 could be one of its partners. Now, myoepithelial tumors of soft tissue are associated with EWSR1 fusions with POUF51, PBX1, PBX3, or ZNF44. Now, sometimes the same fusion partners may cause different diseases even with varying morphologies. So, EWSR1 fusion with CREB3L1 or 2 can give rise to low-grade fibromyxoid sarcoma or sclerosing epithelioid fibrosarcoma. Now, one of the most interesting ones would be the ones on your right. Fusion of EWSR1 with ATF1 or CREB1, it can give rise to tumors with varying morphologies: angiomatoid fibrous histiocytoma, clear cell sarcoma like tumor of the GI tract, primary pulmonary myxoid sarcoma, clear cell odontogenic tumor, and even a salivary clear cell carcinoma. So the tumor that arises out of the EWSR1 gene translocations seem to be dependent on the organ, the type of the cell, the differentiation state of the cell, the exact translocation, and other associated genetic events and abnormalities. So most of those translocations may be recognized through EWSR1 FISH. Now, EWSR1 FISH utilizes a so-called break-apart probe. Now, with the break-apart probe, your probes target the flanks of the gene. So this is an example of a commercial kit for EWSR1 FISH. So one probe covers the 5' side of the EWSR1 gene towards the centromeric end, while the other probe covers the 3' side of the EWSR1 gene towards the telomere. Now, in a normal cell, if the EWSR1 gene is intact, the orange and the green signals would appear close together or blend into a yellow color. But if the gene is translocated, the 5' and the 3' ends would be far apart because one end of the gene is fused to a different gene. So we would see a one fused red-green signal, which represents the normal allele. And then we have one green and one orange signal that are far apart in the nucleus, hence it's called a break-apart probe. EWSR1 FISH is agnostic to the partner gene. It will simply tell you that the EWSR1 gene is translocated. So a positive EWSR1 translocation is not specific for a single entity. So as such, if you have a tumor with an EWSR1 translocation by FISH, it must be interpreted with the clinical, histomorphologic, and immunohistochemical features of the tumor. So we will have an example in the next slide about two small blue round cell tumors that both have EWSR1 translocations. So there are newer sequencing-based platforms such as next-generation sequencing platforms that can identify the partner gene as well, but they're not readily available now in our country. So for now, we're gonna be using FISH. So this is an example of what I've mentioned earlier, that we should interpret the EWSR1 results in the context of the clinical, histomorphologic, and immunohistochemical features of the tumor. So both Ewing sarcoma and desmoplastic small round cell tumor are both small blue round cell tumors. They are both EWSR1 translocated tumors, as we have seen in the previous slide. Both actually occur in younger age groups: children, adolescents, young adults. Classically, they are both composed of uniform small round cells, scant cytoplasm, and distinct cell borders. DSRCT may have a different architecture in which you may have nests of cells in a desmoplastic stroma, hence its name. But what is more useful in differentiating these two would be the IHC pattern. So let's go to the next slide. So here we have Ewing sarcoma at the top row and desmoplastic small round cell tumor at the bottom row. So Ewing sarcoma should be diffusely positive for CD99 exhibiting strong membranous staining. If the staining for CD99 is weak, patchy, focal, or non-membranous, other differential diagnosis must come into consideration. Now, there is an IHC that's being used for Ewing sarcoma, which is NKX2-2, as we see here in the slide, and it is positive in most cases. We're gonna discuss this in the next slide. On the other hand, desmoplastic small blue round cell tumor has a so-called polyphenotypic pattern of IHC expression. So DSRCT shows perinuclear dot-like desmin positivity, but it should be negative for myogenin and MyoD1, which would make rhabdomyosarcoma less likely. DSRCT is also pancytokeratin and EMA positive. It may also express neuron-specific enolase or NSE. CD99 is also variable and it may be cytoplasmic. And that's an example of what I've said earlier, that if CD99 staining is not classic, consider other differential diagnosis aside from Ewing sarcoma. Now, because DSRCT's translocation fuses the N-terminus of EWSR1 with the C-terminus of the WT1 gene, it may stain with WT1-IHC, but your antibody or clone must recognize the C-terminal epitopes of the WT1 protein for it to be useful. Can IHC with NKX2-2 replace molecular testing for Ewing sarcoma? So what's NKX2-2? So NKX2-2 is a downstream target of the EWSR1 Fly1 fusion product. It is also positive in those with EWSR1 ERG translocation, and its sensitivity for genetically confirmed Ewing sarcoma is 93%. However, it is not that specific for Ewing sarcoma. And as you can see on the pictures on the right, it may be positive in other tumors such as mesenchymal chondrosarcoma and olfactory neuroblastoma, which are also small blue round cell tumors. Other tumors with small blue round cell morphology that may occasionally stain positive for NKX2-2 are small cell carcinomas, poorly differentiated synovial sarcomas, Chick ducts 4 translocation sarcomas, neuroblastoma, and myoepithelial soft tissue tumors. So, you can still use NKX2-2 if you have it as part of the IHC panel to increase your pretest probability that the tumor you're dealing with is a Ewing sarcoma in order to justify requesting for EWSR1 molecular testing. So in short, EWSR1 molecular testing may be useful when you are considering Ewing sarcoma and desmoplastic small round cell tumor versus the other differentials. Although usually, these differentials that you see on the bottom row will have characteristic H&E and IHC features that will make you lean towards these diagnoses and instead, work up for these differential diagnoses. For example, mesenchymal chondrosarcoma would have islands of hyaline cartilage, embryonal rhabdomyosarcoma may have positivity for desmin, myogenin, and myo-D1, small cell osteosarcoma would have islands of osteoid. So it is usually in cases wherein these H&E features or the IHC features are not present or equivocal, these are the cases where molecular testing is usually necessary. So from small blue round cell tumors, let's discuss these two cases. Both are from the soft tissue. The one on the left is from the left buttock of a 31-year-old male, and the one on the right is from the right heel of a 44-year-old female. Both are S100 and HMB45 positive. Is it melanoma? Well, the clue is actually in the citation below where the case was extracted from, because the case on the left is a clear cell sarcoma of soft tissue and the case on the right is a melanoma. What's the difference? EWSR1 is translocated in clear cell sarcoma of soft tissue while it is not translocated in a melanoma. Clear cell sarcoma of soft tissue, previously known as melanoma of soft parts, usually occurs in young adults and is located in the deep soft tissue of the extremities. It is composed of nests and fascicles of spindled to epithelioid cells with clear to pale eosinophilic cytoplasm, hence the name. The nuclei have this macronucleoli, just like melanoma. And they may have wreath-like multinucleated giant tumor cells like you see in the picture. Now, the immunohistochemical pattern of clear cell sarcoma of soft tissue is very like melanoma too. So, it's positive for S100, SOX10, HMB45, Melan A. In about half of the cases, you might be able to see melanin pigment too if you look closely enough. Now, clear cell sarcoma of soft tissue is a translocation sarcoma and it's associated with EWSR1 ATF1 fusion in a majority of cases. Now, since it's a translocation sarcoma, we can expect that the cells in clear cell sarcoma of soft tissue would be more uniform. But again, as we all know, melanoma is a great mimicker, so we can't really rely on that feature. Previously, when we suspect clear cell sarcoma of soft tissue, we just ask the clinician if the patient had a previous melanoma because that soft tissue mass could represent metastasis. Now, if there is a history of melanoma, then it likely represents a metastasis. Now, if there is no history of melanoma or the clinician doesn't know or the clinician didn't write anything on the histopath request form, well, we are stuck. So fortunately now, we have EWSR1 tests like FISH, which will be positive for clear cell sarcoma of soft tissue, whichever the translocation is, whether it's EWSR1 ATF1 or EWSR1 CREB1. So from EWSR1, let's now go to SS18. SS18, also known as SYT or SSXT, is a gene located at the long arm of chromosome 18. The normal protein product is ubiquitously expressed in normal tissues where it is presumed to act as a transcriptional coactivator. So translocation of SS18 to SSX1, 2, or 4 on the X chromosome is associated with synovial sarcoma, and this could be detected using break-apart probes similar to that one for EWSR1. Synovial sarcoma is a malignant mesenchymal spindle cell neoplasm with variable epithelial differentiation. There are three main types. First, you have monophasic synovial sarcoma, which is composed of dense cellular sheets or vague fascicles of uniform spindle cells with scanty cytoplasm and bland ovoid nuclei. Now, monophasic synovial sarcoma usually comes up as differential diagnosis in tumors with spindle cell morphology. Next, biphasic synovial sarcoma has spindle cell components that are similar to monophasic synovial sarcoma, but in addition to that, they have an epithelial component which may be in nests, cords, or even outright glands that you see here. Some would even have secretions inside. So, this may come up as a differential diagnosis during the workups for metastatic carcinoma or a soft tissue mass with glandular components. But it is very important to remember that before you consider sarcomas or synovial sarcoma, you must first rule out metastatic carcinoma because metastatic carcinoma is going to be much more common than synovial sarcomas. And then the third would be poorly differentiated synovial sarcoma, and this one is characterized by hypercellularity, high-grade nuclear features, and increased mitotic activity. All three types, the monophasic, biphasic, poorly differentiated synovial sarcoma, they would have translocations of SS18 to either SSX1, SSX2, or rarely SSX4. Immunohistochemistry may be helpful in eliminating many of the differential diagnoses. Pancytokeratin and EMA are positive in almost all cases, and it is strongly positive in the epithelial components and focally positive in the spindle cell components. So if you have a monophasic synovial sarcoma, do not expect it to be diffusely positive. It is just focally positive in the spindle cell components. BCL2 and CD99 are usually positive, but these are not specific. For example, CD99 stains for Ewing sarcoma, and sometimes even synovial sarcoma can have strong membranous staining for CD99, so it's not specific. S100 and SOX10 focal positivity may put malignant peripheral nerve sheath tumor in the differential diagnosis, but almost all synovial sarcomas retain H3K27ME3 staining, which would make MPNST less likely. Synovial sarcomas are negative for CD34, which makes solitary fibrous tumor less likely. Synovial sarcoma is also negative for NKX2-2. Now, there is a newish IHC for synovial sarcoma called TLE1. TLE1 must have diffuse nuclear staining for you to consider synovial sarcoma. TLE1 IHC had been studied for synovial sarcomas. For you to say that it is positive in the context of synovial sarcoma, the staining must be diffuse and strong. Now, the sensitivity of TLE1 IHC is 75 to 100%, and the specificity is 75 to 96% depending on the study, because different studies used different criteria for judging positivity. Most of them would agree that diffuse strong nuclear staining is considered positive. However, most of the studies still had synovial sarcomas that had weak positivity for TLE1. On the flip side, there are also other tumors that stain for TLE1, such as MPNST, solitary fibrous tumor, endometrial stromal sarcoma, liposarcoma, rhabdomyosarcomas. But these tumors usually exhibit weak focal reactivity. And this is the reason why the positive predictive value and the specificity is not perfect. Can TLE1 IHC replace molecular testing for SS18 translocations? After all, TLE1 IHC is cheaper and it is also available in some centers like the Philippine General Hospital. Now, like with all IHCs, TLE1 must be used and interpreted in conjunction with histology and other IHCs. TLE1 positivity alone will not make a tumor synovial sarcoma. The authors who evaluated TLE1 for synovial sarcoma had different opinions with regards to the utility of the IHC. In my practice, I use TLE1 as a screening tool as to whether molecular testing for SS18 translocation should be pursued. Now, if I do TLE1 IHC for diagnostically uncertain cases, there are three possibilities. First, that there is strong nuclear staining for TLE1. So this is considered unequivocally positive. So if it is a classic case in terms of presentation, morphology, and immunohistochemistry, I would sign it out as synovial sarcoma. However, if it does not fit neatly into synovial sarcoma, let's say it occurs outside the usual age group or it occurred in a rare site such as the retroperitoneum, I'd push for FISH or other tests for SS18 translocation. Now, second possibility is that the TLE1 IHC comes out as weak or focal nuclear staining. Now, this is the result in which TLE1 is most unhelpful. So, if the clinical H&E and the other IHC features still favor synovial sarcoma, I'd recommend doing the molecular test. And then lastly, last possibility, what if there is no nuclear staining? Now, this is considered negative, and I would agree with Yagdis et al. That this would obviate the need for molecular testing. Okay, I would not do the molecular test and instead work up the other differential diagnosis instead. So we are near the end of the talk, and I would just want to reiterate key points. First, molecular tests must be selected, considered, and interpreted based on the differential diagnosis made in the context of patient history, clinical findings, histomorphology, and immunohistochemistry findings. MDM2 molecular testing is useful in adipocytic tumors and low-grade spindle cell bone lesions. Now, for low-grade adipocytic lesions, MDM2 FISH testing is recommended for recurrent lesions, deep extremity lesions that are more than 10 centimeters in patients over 50 years of age, in cases with equivocal atypia, in lesions of the retroperitoneum, pelvis, or abdomen, and in special clinical situations as directed by treating clinicians. For high-grade pleomorphic lesions, MDM2 FISH testing is recommended for the diagnosis of the differentiated liposarcoma with no well-differentiated component, for retroperitoneal tumors, for tumors in which the adipocytic component is just seen on the imaging, and when immunohistochemistry shows MDM2 overexpression. EWSR1 gene is a promiscuous gene that may have many translocation partners. Fish with EWSR1 break-apart probes will not give the identity of the partner, and so a positive result must still be interpreted in the proper context. IHC with NKX2-2 can be used to increase the pretest probability of an Ewing sarcoma for ordering a molecular test for EWSR1 translocation. Molecular testing for EWSR1 translocation is the gold standard for differentiating clear cell sarcoma of soft tissue from a malignant melanoma. And TLE1 IHC can be used to screen cases whether molecular testing for SS18 translocation is needed. So I hope you had learned something from this lecture, and thank you very much for listening. Stay safe, everyone!